Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatments across Australia and New Zealand. My name is Rachel Roberts-Thomson and I'm a medical oncologist at the Queen Elizabeth Hospital and with Cancer Care Adelaide. To start with, the Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. And I'm coming to you today from Kaurna land, the land of the Adelaide Plains. We pay our respects to Aboriginal elders past, present and emerging, and we also extend that respect to all Indigenous people. In today's episode, we take a look at BRAF-Mutated non-small cell lung cancer and the recent developments now offering targeted treatments for some of these patients. Thank you to Pierre Fabre for sponsoring this podcast. Today, I'm really excited to have the very knowledgeable panel that we have today to help dissect and review this important topic. I'd like to welcome Professor Ahn Myung-ju, a medical oncologist who's previously worked at Sunshine Coast Hospital and has recently joined the Hanyang University Medical Centre's Department of Haematology and Oncology in South Korea. She's also one of the co-chairs for this year's World Lung Cancer Conference. I'm going to South Korea this year for that conference. Also with us, we have Associate Professor Adnan Nagrial, who's a medical oncologist at Westmead Hospital. So I'd like to welcome them both to TOGA's Conversation in Lung Cancer Research podcast. Now, to start this important topic on treating BRAF-mutated patients with non-small cell lung cancer, I'd like to just briefly summarise the incidence. And we do find this molecular driver, depending on what series you look at, in between 1 and 5% of patients with adenocarcinoma of the lung, and in a very tiny portion, 0.3% of patients with squamous cell carcinoma of the lung. Women and men are fairly equally represented in this finding, and a history of smoking is often part of the picture, particularly in those patients with non-V600 mutations. I'd like to now bring Dr. Adnan to talk about current testing pathways in Australia, the importance of testing for this mutation, and to discuss the different types of mutations that we can find. So thank you, Adnan.
Thanks, Rachel. So thank you to TOGA for asking me to be part of this podcast. It's quite a privilege to be asked to speak. I think Rachel's painted a picture that this is a subtype that occurs in a relatively small subset of patients with adenocarcinoma, but unlike the other oncogene-driven cancers, much more likely to be associated with smoking or ex-smoking. And for us in the Australian population, much more likely to be Caucasian patients that have this mutation. So it really does, I think, highlight the importance of complete comprehensive genomic testing for patients that are diagnosed with non-small cell lung cancer. We already know it's important. We desperately try to re-biopsy patients when they've got a history of either non-smoking or ex-smoking when we think the phenotype is very likely to have an oncogene-driven cancer. But as we're discovering more and more with new drugs coming along, that even patients with potentially very high previous smoking history or smoking history, there's now multiple mutations that occur in that patient population where it's important for us to know. So all the guidelines, including the Australian ones, talk about doing a fairly broad testing for genome testing, and the minimum sort of genes that we should be looking for is now, it's getting bigger and bigger each year, but it's at least on the current guidelines, at least 8 or 9 genes that we really need for anyone diagnosed with lung cancer. So the concept of doing all of that upfront in a comprehensive manner is really important for a number of reasons. So the first being the tissue requirements. If these were to be done gene by gene steadily, you end up using a lot of tissue. Doing it all at once as a comprehensive panel preserves tissue. Doing it as a pathologist-initiated reflex test really does speed up that process. It essentially improves the timeliness of getting that result, so that when they're seeing a patient, when we're seeing a medical oncologist, that patient can have a more comprehensive discussion about what their options are. It reduces the risk that patients miss out on the testing. So we know, particularly from the American community series, that even in 2026, 100% of patients with lung cancer are not getting comprehensive testing. We don't have the same data for Australia to see whether we are similar. I'd like to think that potentially we do better than overseas series, but I don't think there's any reason to think that our systems don't have enough similarities, that there are potentially patients missing out on this testing. And I think that, pathologist-initiated reflex next-generation sequencing probably is the gold standard. One of the limitations in Australia currently is that we don't have ready access to plasma-based ctDNA testing, which would be another tool if we had access to it, potentially improving, reducing the need for repeat biopsies and allowing us to do, serial assessment as well, which really don't have easy access to in Australia. Comprehensive gene testing it differs across the country. In metropolitan Sydney, I think it's fairly comprehensively available as an example, but I'm not sure that's necessarily true in every metropolitan city. And in Australia, it'd be good to get other people's opinions on that. In terms of the testing, so the drugs that we have available now in Australia as well as across the world, where the data is best, is really in that V600E population, which is the class 1 mutations. But we know that if we get a comprehensive gene panel these days, they often will look for the other mutations, so the non-V600E, which can be the class 2 or the class 3 mutations, which the data for BRAF-MEK inhibitors in lung cancer is relatively limited. But when we extrapolate from other cancers like melanoma, which I don't look after, but I know, Rachel, you do, the benefit of BRAF-MEK inhibitors in that population is definitely a lot less. So I think it's important for us to know and be aware that when you get that report, what type of BRAF mutation you're getting reported is really, really important. And so that V600E is vital. I think from a practical sense, I don't have access to next generation sequencing within my hospital. It's sent off-site. So there's inherently a 2-week delay for a comprehensive gene sequencing. We do have access to the IHC, which for V600E in particular can potentially be a good, useful screening tool. We do it a lot in the melanoma patient population when we want a quick result. I've not been doing it for lung cancer as a thought, but we certainly have, it's cheap and it's readily accessible and we can get a result within a few hours. So I think it's something to at least consider because most places would have the IHC antibody. That's sort of, I think, what I was going to talk about. I'm not sure whether Rachel or Professor Ahn, whether you had anything else you wanted to add in terms of that?
Thank you, Adnan. Actually, in Korea, the next generation sequencing is partly reimbursed in carcinoma of the lungs. So still, upfront NGS is some challenge in Korea because the long turnaround time as a first-line therapy. So if we usually do the EGFR, ARC, RAS1, and the PD-L1 testing first, and then if the patient are negative, then we usually do the NGS. So given the very rare instance of BRAF, so still in Korea, the implementation of NGS is still challenging.
Thank you for those insights to both of you. And I guess, now that we've got this mutation able to be targeted, and we'll talk very shortly about the data, it just highlights the importance of knowing whether a patient has this mutation, differentiating between whether it's a V600E mutation or non-V600, and ideally, in an ideal world, having this done reflexively through our laboratories for our patients with short turnaround times. But there are challenges, of course. Professor Myung-ju, I'd be very grateful if you are able to summarize some of the important pivotal trials for patients with BRAF V600E mutated non-small cell lung cancer, and also talk to us about that data, and then we can have maybe a conversation on how we choose best treatments for these patients.
Thank you, Rachel. I'd like to thank TOGA for inviting me to the podcast and, giving me an opportunity to discuss with other experts, Rachel and Adnan today. Where the rationale, the combination of BRAF and MEK inhibitor in BRAF mutant non-small cell lung cancer, given the presence of the oncogenic driver in EGF, the BRAF mutated non-small cell lung cancer, I think the targeted therapy should be considered as an initial treatment approach. However, unlike the other oncogenic, the driven non-small cell lung cancer, the combination strategy may need to be considered in BRAF mutant. Because the biological rationale of the combination is very clear, the BRAF activated the MAP kinase pathway, but we just inhibit the BRAF alone, we may see the incomplete pathway suppression and paradoxical MAP kinase activation, which lead to the skin toxicity and the resistance. So adding the MAG inhibition gives a deeper, pathway blockade and improve clinical activity. So given that the first combination agent, dabrafenib plus trametinib in phase 2 study in BRAF non-small cell lung cancer as treatment naive and the previous treated patient, the dabrafenib plus trametinib showed the ORR 68%, median PFS 10.2 months, median OS 18 months is 57 previously treated patient, whereas the ORR 64%, median PFS 10.8 months, median OS 17 months in 36 patients with treatment naive patient. So this result leading to the FDA approval in 2022. So, and then next study is a PAROS study, which I participate in. The combination of encorafenib plus bimetidine, also in treatment naive and the previous treated BRAF V600E non-small cell lung cancer. The PAROS study showed quite interesting data. The ORR 49%, median PFS 9 months, OS 22 months in the 39 previously treated patient, whereas the ORR 75%, median PFS 30 months, and the OS 47 months in the treatment naive patient. So compared, it's a little challenging to have the cross and the study between the dabrafenib, trametinib, and the encorafenib plus bimetidine. But as a first line, it seems that encorafenib plus bimetidine is showed a long PFS and OS so far. So also this drug is also approved by the FDA. So they're very impressive. So do these two combination, the agent, the data that we have, and then also two combination agent approved in worldwide.
No, thank you, Professor Myung-ju, for that summary. I think we have seen from these studies that there are quite high objective response rates, durable response. There's sort of 5-year data now from PAROS, so high response rates, some durable responses. And it was interesting that the response rate for the treatment-naive patients in PAROS was higher than for those who had previously been treated. One of the dilemmas, I guess, we have for these patients is whether, or we know that these patients can respond to immunotherapy, unlike a lot of our oncogenic driving non-small cell lung cancer patients. But we have this choice, don't we, on whether to look at targeted therapy first with dabrafenib and trametinib or encorafenib and bimetidine, or to look at chemotherapy with immunotherapy. So I'd be keen to ask you how you make decisions for your patients regarding that, and whether there's subgroups, particularly highlighted in the FAST-BRAF study, another important study. How do you make decisions? And I'll also ask Adnan as well this question, but keen to know how you make decisions for your patients.
So unlike the EGFR or ARC, the BRAF-mutant non-small cell lung cancer is not uniformly immunotherapy resistant. So because the many patients, especially smokers, and then they may have a high mutation, the tumor mutation burden, and then they may benefit from the chemoimmunotherapy. You just said that several studies show that chemo IO comparable to the targeted therapy, but most of the studies are retrospective, so we need a prospective study to identify who may benefit from the first-line immune checkpoint inhibitor plus minus chemo rather than the targeted therapy. However, my personal preference is use the targeted therapy early, especially the patient, the rapid tumor shrinkage required because the response is very high and the target is clear. However, in patients with smokers and the high PD-L1 and the high tumor mutation burden, the chemo IO might be more reasonable. So I think I would individualize according to the patient characteristics. So if the patient have the symptomatic high tumor burden, brain mass, which need the rapid response, I think the target therapy is very attractive. If the patient, the clinical stable, have a smoker, high PD-L1, and if the access to the target therapy is limited, I think the chemo IO may be the reasonable first options.
Thank you. I think that's a great summary, isn't it? And you've highlighted also the intracranial efficacy, which I think is important for our patients. And then maybe using other things like smoking history, high PD-L1. We don't always have access upfront to TMB and whether they've got a co-mutation of TP53, but there might be some ways to choose a treatment for your patient. But it is nice to have two effective lines of treatment for these patients, isn't it? So, Adnan, I'm keen to hear your thoughts on, how you might choose the treatment pathway for your patients.
Yeah, thanks. So look, as you know, Rachel, it's a relatively new issue for us because dabrafenib, trametinib's only got on the PBS relatively recently here in Australia for that indication. So outside of trial, it's really now we're having this conversation. I think as Professor Ahn said, the challenge is we don't really have any randomized data to tell us. And so there's a lot of extrapolation. There is a retrospective series that have shown that, to be honest, giving immunotherapy first, if you can, safely, may potentially be a better strategy. In the retrospective series, the overall survival seems longer in the patients that get immunotherapy first and BRAF second. It's very selective, obviously, it's retrospective. So I think, as Professor Ahn said, my thoughts are that, when I have this next patient in clinic tomorrow, where I could give potentially either therapy, the thoughts I'd have would be, what is that PD-L1 level? The 90% patient, I'm much more inclined to really consider immunotherapy first versus the 1% or PD-L1 low. Definitely for the PD-L1 zero, I think I'd be leaning towards a BRAF-MEK inhibitor combination. The patient with CNS metastases that are symptomatic, requiring steroids, as an example, the sort of patient where you would worry that immunotherapy is potentially going to be less effective and you need a response. And we know that these patients are more likely to have a history of smoking just as a generic rule. So if they've, again, got a heavy smoking history and therefore more likely to have a high TMB, which we don't have as a number usually when we see the patient, but you can sort of assume, again, more likely to offer immunotherapy. I think the other thing we know from this retrospective series is that the sequence of giving the BRAF-MEK inhibitor after immunotherapy is safer than we probably thought initially. It doesn't seem to cause increased toxicity if you give that sequence. Obviously, the reverse sequence you can do as well. But again, this is talking to my melanoma colleagues about the use of BRAF-MEK inhibitor. They also tend to have the similar view. Giving immunotherapy first in that BRAF V600E patient population is what they try to do as much as they can. And the risk is if you give the BRAF-MEK first and then there's resistance that develops, there can be relatively rapid progression where you don't get that good period of second-line therapy if you stop the BRAF-MEK inhibitor and try to switch to alternative therapies. So I think putting all of that together makes me more inclined to offer immunotherapy to the majority of patients, unless there is a really compelling reason that immunotherapy is less likely to work, non-smoking, PD-L1 zero, or brain mets requiring steroids, or anyone requiring steroids for any reason. I'd be probably less inclined. But we don't have randomized data. So obviously that'd be the ideal. The additional thing obviously is the combination. Can we give immunotherapy with BRAF-MEK inhibitor? We've seen studies that show that it can be done, but it's challenging with some combinations. And still not convinced that I've seen any data that tells us that it's synergistic and we should give it together and get a additional benefit. But in lung cancer specifically, I'm not sure we've seen enough data yet to be sure of the answer to that question. So I think similar to what Professor Ahn said, I'd approach it in a similar way.
Look, they're great insights and summaries, I think. And I think, very useful to have these discussions and try and make the best decisions for our patients. And also just highlighting that it's for the BRAF V600E mutation patients, because obviously we don't have the data for the targeted therapy in the non-V600 patients, and they are different behaving mutations. No, they're wonderful summaries. So moving on, Adnan, I think it may be useful to highlight to our audience the practical management with these targeted therapies. So I'm hoping to ask you how you manage Pyrexia syndrome and how you educate your patients around that potential toxicity for patients.
Yeah, so I think for thoracic oncologists in particular, these are relatively unique drugs. So we only have dabrafenib, trametinib on the PBS. Professor Ahn's mentioned the other alternative, encobini, which we may get access to in the future. But I think the common side effects that we deal with many TKIs occur fairly commonly. So there is, when you look at the studies, about 50% of patients got some level of fatigue, similar number get some level of nausea. I think we're all relatively comfortable managing that. But the unique side effect, which you mentioned already with the DAB-TRAM and the BRAF-MEK combination in general, is significant pyrexia that can occur in some patients. So typically what will happen, and it's fairly common. So again, more than half the patients on the studies with dabrafenib, trametinib in particular, develop pyrexia during treatment. Typically occurs relatively early, so usually in the first month. And generally what they'll present with is a genuine fever. So someone will, so the classic will be they started the therapy and about 2 weeks in, they'll call or they'll show up to clinic and they've had temperatures of 38.5 or higher for, 24 hours or so. And it can be associated with sepsis type symptoms. So you can get concerned, they can have drills, they can have rigors, nitrates, etc., with a genuine fever. I think the main lesson really to take is you've got to stop the therapy. So trying to manage it when they've got real genuine temperatures by cutting dose or just starting paracetamol or any other medication probably isn't the way to go. The best treatment is to actually stop the drug. It tends to settle down fairly quickly. And if you've had, my usual practice is if they've had at least 24 hours where the fevers have settled, I generally restart. Usually at the same dose is my usual standard to restart initially, but then watch them carefully for the next few days. If they spike a fever again, I then again withhold, wait for the drug to wear off, and then I usually will try restarting again, but with steroid cover. So I tend to start with a little bit of prednisone, and that often will be enough. If that still doesn't work, then I start looking at dose reduction. So that's generally the way I approach it. Not sure, Rachel or Professor Ahn, whether you do anything differently. And I know you, Rachel in particular, I know you see a lot of melanoma patients, so whether you do anything differently. I think the other unique things about the drugs that I think it's worth, keeping in mind, because it's not something we think about with other TKIs and lung cancer, is there's a relatively high rate of hyperglycemia with DAB-TRAM as well. So at least checking that every so often, keeping an eye on it. And the rarer side effects, it can affect the vision, MEK inhibitors in particular. So being very cognizant of eye symptoms and getting prompt review and potentially stopping the medication temporarily while that's investigated, I think is important. And the other side effects are relatively common that we're all used to, LFT derangement and potentially ILD and things that lung cancer oncologists, we tend to look at fairly commonly. So I think that sort of summarizes what I do with the patients I've seen. I'm not sure if others have different view.
I think that's a great summary, that really quick stopping of the BRAF and MEK inhibitor combination with any fever, chills or shakes. I tend to maybe stop for a little bit longer, 48 hours, but a very similar way to address that problem, and education of patients is very important. Panadol fluids. Professor Myung-ju, with your experience on the FARO trial with encorafenib and binimetinib, would you like to make a comment on your experience? Yeah.
Yes. Actually, I participate in the BOST trial, dabrafenib, trametinib combination, and the encorafenib, the binimetinib. And it's hard to compare, but the report suggests that the encorafenib and binimetinib has a very less incidence of pyrexia, around 20%, and the grade 3 is 0%. So from my several patients, no pyrexia at all. So it's just quite different from the dabrafenib and trametinib. So for using the dabrafenib and trametinib, and you already mentioned that I educate the patient that this drug is occurred that developed the pyrexia, and I give the antipyretics proactively, and also the Adnan already mentioned that when the developed the fever developed, I just stopped the drug right away. And then I give the Pyrexia. But after 2 episodes, I usually reduce the dose, not third episode. So that's my, and also if the patient, persistent have the fever more than 48 hours, I give some low dose steroid to control the fever. So that's my approach.
No, look, thank you very much for those insights. That's been very helpful. So yes, we've talked about the importance of finding this BRAF mutation in our patients with non-small cell lung cancer. We've talked about how some of the data to support the use of targeted therapy in this setting, and we've talked a little bit about the toxicity of the treatments. There'll be lots on the horizon, I think, a little bit more on how we sequence our treatments. There'll be more about resistance mechanisms and how we learn to treat the non-V600 mutations. So a lot of things, I think, that are predicted to be questions for the future. That nicely brings us to the end of this episode. I'd really like to thank Professor Myung-ju and Associate Professor Nagrial for joining the discussion and for their wonderful insights. Once again, we thank PFAB for sponsoring this podcast. And as always, thanks for listening to TOGA's Conversations in Lung Cancer Research.
Thank you.
Thanks, Rachel.